Well, good afternoon, everybody. We thank you again for joining us on this multi-part webinar series brought to you by the University of Texas School of Public Health and the Houston Area Safety Council. If you've been a part of these weekly webinars, we welcome you back. If this is your first time jumping on, welcome to those. And today we're going to be talking about places of worship. A very important topic to discuss as many Americans yearn to go back to their place of worship and get things back to normal. So again, we welcome you onto this webinar. We hope you enjoy it. Throughout the webinar, all of the attendees are muted, so you can't talk to us. If you're talking to us, we can't hear you. So, but you do have the option of typing in a question that you would like us to answer in the question box that you should see on as part of your app or the desktop there. So just feel free to type in those questions. We encourage questions. This is a Q&A webinar. We're gonna provide a few facts up front, some updates about this virus, but the majority of this hour-and-a-half webinar is dedicated to answering questions that you give us. So please type in those questions so we can keep this an informal and dialogue. Webinar is brought to you two major entities. One is the University of Texas School of Public Health with a mission of changing the culture of health. The second one is the Houston Area Safety Council, and our mission is building safe workplaces. So the goal of these two entities collaborating is to provide you some resources to help you navigate through this pandemic. It's a scary time. It's a lot of the information that we have on this virus is new and ongoing. We learn things every day. We change things every day. So we're trying to provide you that knowledge, guidance to help you navigate during this pandemic. So we hope you enjoy it. We're glad that you're here. We want to thank our platinum sponsors of the Houston Area Safety Council. We could not provide these webinars and extra services to you guys without the support of our partners and our sponsors. So thank you to our highest level platinum sponsors. We appreciate your support. So a quick overview of what we're going to talk about. The governor of Texas came out with his Open Texas initiative and executive order. So we're going to highlight today, of course, the places of worship, what that mandate tells us, what are the guidelines from the CDC that they recommend we try to adhere to when we go back to work and we go back to our place of worship. We're going to talk about some terminology, masks, masking versus face coverings, what some of those things mean, what places of worship can do to reduce the spread of this virus. We don't want this virus in a place of worship. If it happens to enter into the place of worship, what can we do to make sure that the congregants are not at risk for getting that virus while they are worshiping? But moreover, it's going to be a question and answer type webinar. So please feel free to type in those questions into that question bank. So here's our list of all of our guest panelists today. We have several representatives from the University of Texas School of Public Health, as well as some guest panelists on today. And I'm going to turn it over to Dr. Janelle Rios to introduce everyone.
Hi, good morning, everybody. My name is Janelle Rios, and I'm a faculty associate at the School of Public Health. We've assembled a group of experienced and thoughtful faith leaders who serve as luminaries in our collective communities. And it's my great honor to introduce them as our guest panelists today. We have Rabbi David Lyon, who was ordained in 1990 and has served as senior rabbi of Congregational Beth Israel in Houston since 2004. He is also vice president of the Central Conference of American Rabbis and serves on the national board of the Jewish Community Legacy Project. In Houston, Rabbi Lyon is a board member of the United Way of Greater Houston, board member of Interfaith Ministries, a member of the ADL's Coalition for Mutual Respect, and a member of the advisory board of the Holocaust Museum of Houston. He's also a lifetime honorary board member of the Institute for Spirituality and Health at the Texas Medical Center. We also have, and he may be having difficulty joining the webinar, but hopefully he will join soon, Imam Muslin Khan. Imam Khan completed a 7-year course in religious studies and in 2013 was assigned to serve as a missionary of the Ahmadiyya Muslim community in the United States. He has been serving in Houston since 2017. And I thank Dr. Amir Malik for introducing him to us. We also have Reverend Jim Bass, who has been the senior pastor of Friendswood Methodist since his appointment in June 2006. Previous to coming to Friendswood, Jim has pastored churches in Alvin, East Texas, West Houston, and Beaumont. He graduated from Southwestern University with a degree in history and a minor in Greek. He received his master's in divinity degree from Perkins School of Theology at SMU in Dallas. And SMU is my alma mater as well. So I have a connection with you, Reverend Bass. Please join me in welcoming our guest panelists. Thank you so much. Back to you, Tommy.
All right, thank you, Janelle, for that great introduction there. So, just to kind of kick us off and give some context to what we're going to be talking about, the governor of Texas rolled out his executive mandates several months ago, I guess now, at least a month ago. And one of the highlighted areas of returning was places of worship. So I took some screenshots of, it's a 3-page guidance document that is posted on the governor's website. And it gives some specific guidelines to what places of worship need to do in order to safely return their worshipers back to that facility. So a good starting point to look at and to make sure that, not only is the place of worship doing these recommendations, but also the attendees are adhering to what is recommended. The CDC also has some guidance out there. It's called the Interim Guidance for Communities of Faith. It's on their website. It goes into some of that detail about what to do to help reduce that risk of spread at that place of worship. So these are websites you can go to right now and take a look and see what the experts are recommending and what the government is recommending. The United States is for the most part a country of faith, and a place of worship is not about the building itself. It's about the people. Without the people, there is no congregation, right? But unfortunately, this virus is also a virus of the people. So most of these places are built upon interaction. That's the foundation of a service and a congregation, is interacting, being together, shaking hands, hugging, singing, sharing communion, passing an offering plate, touching and interacting in close contacts. And what does this virus do? It spreads by close contact. So it goes without saying that this has been an area of fear and hesitancy for not only local communities and rabbis and pastors and imams, but also the highest level of government. The CDC has been leery of saying, yeah, go back and worship as you used to. It's a hot topic right now. How do we open up safely? So hopefully today's webinar will give some guidance to everybody that's attending today. We're also going to hear from our wonderful guest panelists to tell us what they're doing at their places of worship, what their heartaches are, what are they most concerned about, what are the biggest fears that the worship goers are providing, giving feedback on, and hopefully help reduce some of those fears to everybody. So without further ado, I'm going to pass it over to George Delclose to give us some updates on this virus. George, I think you're muted.
Gee, I was almost finished. No, I'm kidding. Sorry about that. So every week I do give some updated statistics, simple statistics, but I think informative, because when the governor first came out with his order, that was on April 17th, although the reopening officially began around May 1, one of the comments that was made is that the decisions, the progression from one phase to the next phase was going to be data-driven and scientifically driven. And so numbers are important, but they need to be put into context. So this is an update that we have data from some of our colleagues here at the Department of Biostatistics, specifically Dr. Jose Miguel Yamal, who every week I bug for the most recent data. And what you see on the screen here is the data of number of new cases per day in Texas, starting back in March, when even before the shelter-in-place recommendations were put into place. And you can see on the left of the screen that the cases, the blue line was increasing. Then we did the shelter-in-place began. The numbers continued to increase, which was not unexpected because it takes about 2 weeks from when you were exposed or when you intervene, like sheltering in place, to see the effects of that intervention. And at 2 weeks, and again, this is across the state of Texas, the speed of ascent, of climb of the curve started to flatten out, but then we began the reopening, and the numbers have continued to rise. Again, these are number of new cases per day. With each successive reopening, the numbers have gone up for Texas. However, the numbers for Texas do not necessarily reflect local numbers. And so for all congregations, it's important, I think, to think locally, or to act locally and think locally in benefit of the entire state. So next slide, please. So if you look, for example, this is from the Johns Hopkins website, you'll see that Texas, this is the distribution of daily increases in cases, what we call incidence rate. And you see that without going into a lot of detail, Texas is a patchwork of colors. The lighter colors mean fewer or even no cases. In the Big Bend area, there essentially been no cases reported. Not a surprise, since the parks were closed and there's not much else out there. The darker purple are the hot spots in the state. And so it tells you that even though we saw in the previous slide the overall numbers for Texas, there is tremendous variability. Next slide. So in this sense, previous one. Yeah, so this is the curve for Houston, the greater Houston area. That means all the surrounding counties, including Galveston area. We see the cases were climbing before the shelter in place began, and that there was, 2 weeks after the shelter in place began, there was a clear-cut drop in the number of cases. Then we began the reopening. It's held steady, but at 2 weeks, you started to see it creeping up, and now it's creeping up again. Now, no increases in number of new cases. Were not necessarily unexpected. We had Memorial Day weekend, which a lot of folks were concerned about might lead to an increase in cases. We had the protests last week. It's too early to tell whether that had any effect or not, although all indications suggest that at least in Texas, the majority of people were wearing masks during the protests, which is good, and it was outdoors, which is probably associated with a lower risk of transmission. But notice how the local pattern differs from the state pattern. But looking at daily number of cases is not enough. We got to drill down. So next slide. One of the things that is very important is to look at the rate of hospitalizations. I think everybody is aware of the fact that when it hit New York or Washington State or California early, even before Houston, the hospitals rapidly were overwhelmed, especially in New York. We never got to that in Texas or in the greater Houston area. I think personally, it was thanks to how soon we started taking this seriously. We actually started taking it seriously before the numbers started hitting the US, at least in the Texas Medical Center in Houston. And so we never got above the maximum capacity of hospital beds or ICU beds or ventilators or protective equipment. But if we look at the trends here, and this again goes back to March, there was an increase in March coinciding with the rapid increase in numbers of cases in the greater Houston area. But then we did a bunch of things in the Texas Medical Center. We emptied out beds. We stopped doing elective procedures. We started adding to the surge capacity of the hospital so that this red line, which is hospitalizations, it's not total cases, hospitalizations began to decrease until you start hitting May 1, again with the reopening. And then since then, it's been steadily increasing. Now we are still well below our surge capacity, but we need to keep in mind this increase in hospitalizations because it may continue to increase. Last slide, please. So one of the things that we do in the medical centers, we have a series of metrics to make sure that we have enough capacity built in to be able to handle sharp increases in cases that are being hospitalized. You know, if the only increase in cases every day was for people who didn't wind up in a hospital and did okay, they got over their infections at home, that would be very different. And the hospitalization rates weren't increasing. That would be important to know. But we are seeing that there is, as I said, a parallel increase in hospitalization. So we monitor different trends. I'm not going to go through all of them, but they have to do with availability of ICUs, equipment, personal protective equipment needs. And over here in the red, green, yellow, these are our indicators of how well we are doing as the medical center. And last week, if I had shown you this, when I showed this graph, there was only one dot that was yellow. Now we have 2 dots. So the 7-day running average of growth in number of cases hospitalized is going up. It's yellow, it's not red. We're not in the panic area, but it is an upward trend that we need to keep an eye on. And the same thing with ICU beds. We still have plenty of ICU beds, but it's going up and we need to keep an eye on this. So bottom line is, as you are thinking about reopening your places of worship, it's important to keep the data in mind, I think, and especially your local data, because your neighborhood or the membership of your congregation may differ tremendously from other parts of the state. Next slide. One way of one thought you might want to give is at the School of Public Health at the University of Texas, we have signed on to a project that is free, that was initiated by Harvard University about 2 months ago, which is an app that can be downloaded into an iPhone, and that allows people, any citizen, to track their daily symptoms or absence of symptoms. And the reason it says it takes 1 to 3 minutes to complete. I've done it. It actually takes less than 30 seconds to complete. And it's it's totally de-identified, anonymous data, but we analyze it at the School of Public Health, and we can give breakdowns by county or maybe even by zip codes. Why do we think that this could be useful to you? Next slide. It's because for people, for example, businesses or places of worship in these areas could use the findings from their zip code area or their county area to help guide their own individual decision for their congregations. If you see that in your local area, the prevalence, the frequency of people reporting symptoms goes up, that might want to make you think twice about taking the next step. Or conversely, if you see that it's okay, that it's staying steady, that might be an indication that it's okay to move to the next step in reopening. So I just wanted to make you aware of that. We are going to make all of these slides available to everybody on our website, so all of the links and all that will be available to you. Thank you. I'll pass it on to Janelle now.
Perfect. Janelle, and I see that Imam Khan is on here, so I'll let you introduce him as well.
Yes. Hi, let me turn on my camera. And Imam Khan, thank you so much for joining. I had introduced you at the very beginning. We really appreciate that you are here with us today. Again, everybody, my name is Janelle Rios, and I'm a faculty associate at the School of Public Health. And what I'd like to very briefly share with you today is a well-known and often used public health tool that serves as the foundation for controlling hazards. And typically, we control hazards at the workplace. And I've adapted this to a certain extent for places of worship. And it's called the hierarchy of controls, again, for controlling the hazard. And hierarchy refers to the level of effectiveness of each of those controls. Now, we see a lot in the news, face masks and issues regarding personal protective equipment. Personal protective equipment is down at the very bottom in red of this inverted pyramid. And off to the right-hand side, you see that that is the least effective control method for controlling hazards. The most effective method is elimination, and that really refers to eliminating the hazard from the facility, or in this case, the house of worship. And to eliminate the hazard, we suggest establishing practices to keep the virus from entering the actual building. And that would include things like encouraging people to screen themselves at home and to stay home if they are ill, if they have any symptoms. Webcasting services, if that's possible, and encouraging facial coverings. And I have some examples of cloth facial coverings here. And keep in mind that facial coverings are to protect others from you versus personal protective equipment at the bottom of the pyramid, which is to protect you from others. And Bob Emery will get into that a little bit more in a moment. For engineering controls, we suggest looking at your HVAC technologies and increasing air exchanges or considering inline UV technology to disinfect the air that's coming into the building. Having stations where folks can wash their hands or at least sanitize their hands, and signage as reminders to remain 6 feet apart, to wash your hands often, and to avoid touching your face. I know I'm a face toucher, and that's really hard for me to remember. So having signage in your house of worship would be helpful for folks so that they remember not to touch their face. Some administrative controls, and that's really, historically, that's how people do the work, how the work is performed. Here for a house of worship, we do recommend offering training on what to look for when you're screening yourself at home. You know, an elevated temperature, a cough, a lack of a sense of smell or taste. What else to look for at home? Also, resilience training. Consider that for your congregation. These are stressful times that we're living in right now, and sometimes if we are stressed with other things, especially a loss of a job, a loss of a loved one, other stressors at home, and this is on top of it, some resilience training would be very helpful to your community. Encourage holding meetings with telecommuting technology and video conferencing. You know, I've become an expert in Zoom and WebEx and GoToMeetings and other training that you can offer your communities. Organize your services and your outreach activities to limit physical contact when at all possible. Now, in places of worship, people don't just come to this place of worship. I think that faith leaders also go out into the community. That could be hospitals to do it, and funerals and other life settings. And so limit the amount of physical contact that you have when at all possible. And I also understand that places of worship serve as community hubs for things like hosting the homeless or food banks or other activities like that. So again, keeping that in mind and limiting physical contact when at all possible. And then last but not least is personal protective equipment. Have those supplies readily available. Those could include things like gloves or actual personal protective equipment. And this is an N95 respirator that is fit tested on a person. This actually protects the wearer from people who may be positive with COVID-19. And I think that was, oh, and one other thing, as I was adjusting this slide for places of worship, I removed and forgot to put back in the use of cleaners and disinfectants. As you use the cleaners, be aware whether or not they are EPA registered, and we do highly recommend that you use only EPA registered disinfectants, and that you use them in accordance with the manufacturer's instructions. And that could include using concentrated, if you dilute it, and then maintaining a sufficient contact time. So, and I meant to put that back into the slide and I completely forgot. So I apologize for that, but you have this recording, and I welcome your questions at the end of this presentation. Thank you.
Thanks, Janelle. I believe we have Bob. All right, Bob, take it away.
So, hi, Bob Emery, I have 4 points, but I think a couple of them have already been covered, but just would like to reinforce this, that unfortunately in the media, this particular ailment is a novel coronavirus, but the problem is the term novel has kind of fallen off the radar screen. But I would encourage each of everybody that's on this to keep in mind that novel means new. And so there are aspects associated with this virus that are known, but there's some that are not known. And if you kind of think back, the notion of early on in this game, we were worried about travel history and these sorts of things, and we got community spread. The notion that the virus could be spread even though someone was asymptomatic. I think it's important for all of us to communicate to our constituencies that there are things that we know, and these are the controls we can put in place, but understand there may be some new things that evolve, and we're going to have to adapt to that. My commentary is that in the world of epidemiology, one of the things that we track quite closely is what's called the R0 value, that R sub 0, and that's the projected number of additional cases. So if you have one confirmed case, how many additional cases might you expect? And the current estimate is a 2.2. And of course that will evolve as more data is provided. But to put that in perspective, and George helped me with this one, but I think influenza, like the seasonal influenza, is about 1.2, correct?
Around 1.6.
Yeah, so okay. But on the other end of the spectrum, something like measles is like 15, right? So one of the things you kind of want to know about is that's kind of the blood pressure indicator. You want to know what's going on there is the R0 value. So that's item number 1. Item number 2, screening. We get inundated with calls here about the notion of temperature screening upon entry and these sorts of things. I would just encourage everyone to communicate to their constituencies that screening begins at home. And that's, I think, to underscore what Janelle was saying, that, you know, if you're not feeling well, or you perhaps someone in your family or close circle has maybe received a confirmed case, this sort of thing, stay at home. I'm not sure at this point, and again, I'll defer to my colleagues here, but I'm not sure that temperature screening is effective at all at this point, because you could be asymptomatic and or you could be taking medications that depress the temperature point. I'll pause there for a second. Tommy, George, you guys okay with that? Okay, we're getting a thumbs up on that one. Okay, all right, I got it. Third one has to do with masking. Just so everyone is crystal clear, that because it appears as though this virus can be transmitted by something simple as speaking and or singing, which I think we're going to get to when there's going to be questions coming in on this, that there are this, it's been, that's why we're seeing the notion of face coverings. So in the notion of the surgical mask or the face coverings, but that is intended only to keep you from possibly inadvertently transmitting the disease to someone else. It is not intended to protect you. That's where we get into the personal protective equipment such as N95s, P100s, and others. And so just want to make sure people understand the difference between that. And then last but not least has to do with cleaning and disinfecting. And I would underscore what Janelle said, that number one, whatever product that you're using to clean or disinfect your facility, go to the EPA site. They have a nice little thing, and confirm that is it that number one, it's an EPA registered disinfectant for this virus, number one. Number two, ensure that if you're getting it in some sort of concentrated way, that the folks are, whoever it is doing it, are mixing it and applying it appropriately. I remember 100 years ago, my dad thought, well, if we get some yard fertilizer, if this amount was good, we'll put twice the amount and we'll get more grass growing. There were 8 kids, by the way. And, you know, but in fact, it just burned the grass up and killed everything. So make sure that it's being mixed appropriately. And then most importantly, and underline this one twice, is contact time. Because they're going to specifically say, how long does this product need to be on a surface for it to be effective to render that virus inactive? And what I'm seeing time and time again is go to these different places and people are going up and they're spraying and then they immediately wipe it off. And it's like, wait a minute, time out. You know, let's make sure we evaluate contact time. And then my last point is that one of the things I'm now experiencing is as organizations and companies are trying to, what I would refer to as engineer in social distancing. So we've done one of these for restaurants, for example, that they might remove some tables or remove some chairs or whatever. But unfortunately, all of that surplus furniture is getting stacked up right in front of the fire exits. So as you think about your congregations and whatever sort of engineering controls you consider, please keep that in mind as well. And then I'll stop yapping and try to answer any questions that you have. So thank you for the important work that you guys do, by the way.
Thanks, Bob. You know, I do have a question as we're going, and I'm sure some people may have this as well. But so talk about why it's, you know, maybe just a couple of sentences, why it's important to use an EPA registered disinfectant. Is that to protect the environment? Is that to protect the people from toxicity? Why go off of that list?
Because there is a rigorous testing protocol that the EPA subjects vendors to confirm that that product renders that virus or whatever it is, you know, whatever they're marketing that product for, it actually works. And
well,
so,
that's great to know. I think sometimes when people see EPA, they think we're trying to prevent global warming. So, you know, so it's truly to see what product works to kill this virus.
Correct. Yeah, that's correct. Yes.
Gotcha. Perfect. All right, Dr. Dufresne, Dave, are you up next?
This is Bob's reference list, so I expect a full book report from everyone on this webinar after you read those things. So.
And just to that point, nobody has to write these down or memorize these or take screenshots. We're going to send this whole slide presentation out to everybody with a full link to the recorded whole webinar, so you can have this at your fingertips.
So thanks, Tommy. This is Dave Dufresne. I'm over here at our San Antonio campus, and my responsibility was to put together a slide that provides you with some guidelines as far as houses of worship. And this particular slide just augments the previous slide that Bob put together. As I researched around on this particular webinar and the resources that are out there, there is a plethora, you like that, Bob? A plethora of guidelines and resources for different denominations, and all the different religious denominations have their church associations that are just pumping out the different guidelines and resources. And so instead of putting all of those on one slide, I thought I would just put together just a nice tight slide, just some broad guidelines. The first link there is the CDC website that Tommy mentioned at the beginning of the webinar. And then also the Occupational Safety and Health Administration, which is our federal regulatory body as it relates to worker health and safety, they have put out some resources related to COVA. The third link there is from the state government regarding churches and places of worship. And then lastly, what I would like to draw your attention to is the American Industrial Hygiene Association. And they really have a very nice website with a whole host of resources and guidelines broken down by industrial sector, and included in that are worship services and religious gatherings. And so I strongly encourage you to look at this particular one, and they have some very nice resources, not only for churches, but also for every single other sector that you might be able to find some nice pearls in there as to your different activities at your churches and houses of worship. So I'll turn it back over to Tommy, and I think we're going to open it up to the panel for an open discussion.
Yes, sir. Perfect. And what I did on this slide is I took the CDC's guidance as well as the governor's executive mandate guidance and kind of compiled it into a concise list. So for those, who are in charge of putting in processes at their places of worship to reduce this virus risk, here's a nice little bullet point list of things that at least the CDC and the governor say you should do. And we talked about all of these, I think, during the webinar. I think we're going to talk about them more. But if you did these, I think you'd be on the right track of doing a lot. If you can do more, great. But these were definitely a consensus of both of those CDC and the state's recommendations for what we can do to mitigate that risk. So some easy things to put in place. Nothing costs a lot of money. But again, it's trying to, make sure the location is clean and that people are protected and covered when they come back to the place of worship. So again, we're going to disseminate all of this information out. So with that, what I'm going to do is just start to throw out some questions that people have typed in or written in to our guests, and as well as our experts on the panel today. I'm trying to go back to the slide there. So
Tommy, it's Bob. I'm just wondering if it might be worthwhile just take a moment to ping our other panelists to ask them what they are apprehensive or what they're
absolutely definitely. And it's a good question. I think my first question would be, I'll go down the list. I'll start with Jim. And when has your facility, or when is your facility planning to open up to a congregation?
We are actually starting this Sunday, June 14th, to resume in-person worship. We've adjusted worship times to allow greater space, to allow people to leave campus, so there's not a lot of congestion in the halls and such. We've obviously roped off different pews, every other pew, to provide social distancing. We've secured about a dozen sanitizing stations, asking people to sanitize their hands upon entering and upon leaving. We've had a member of the church build offering boxes for us, so we're not having offerings. A plan to put in to disinfect the worship space, particularly the pew handles and the tops in between those services, all the doors. We have some custodial crew also on site on Sunday to disinfect bathrooms and such like that throughout the morning. So we're beginning in that process. We're also continuing our online worship. In fact, as soon as this is done, I'm going to go over and tape the message for this coming Sunday. We'll continue to do that until we've invested quite a bit of resources into being able to live stream our services. And so we will do that when we feel that is at the level we want it to be. So.
Gotcha. Thank you, Jim. David, how about you guys? Are you open for business yet?
We are open online. I think we really take our cue from some sacred teachings. One, I think you'll appreciate, it says, don't put yourself in a dangerous place, and then pray for a miracle. So we're taking ourselves seriously, but also the fact that our constituents, our congregants, will not come, even if we invite them, into a place that they don't feel is ready for them to enter. And so they're listening to the data too, and they're telling us, pace yourselves and go slowly. But as a result, we've been preparing well. We've had years of live streaming, so we've augmented our services to be online. My clergy team have various levels of confidence about returning to our worship space, our bema or altar, as you would call it. But I think by July, we'll probably use our largest worship space, our main sanctuary that seats 950 people at most, to come in and socially distance from each other. The truth is that the CDC guidelines, even the governor's guidelines, weren't bad, very helpful. If we can abide by them and provide the resources for people to come in and exercise personal hygiene, and we can disinfect and all the things that you've mentioned here, we can probably slowly increase confidence so that people will return. I'll just finish by saying that our goal line, so to speak, is our High Holy Day season in the fall. When Rosh Hashanah, the Jewish New Year, and Yom Kippur, the Day of Atonement, begin in mid-September this year, this is a time when people don't mind live streaming, but they have an urge to be in their worship space to accomplish what they need to do. So we're giving ourselves time and using the guidelines to prepare appropriately.
Thank you very much. And I'll turn it over to Imam Khan to talk about the mosques.
Yes. So our mosque is presently closed. We come under a national organization which is making decisions for mosques belonging to our community across the country. So the general guideline that they've given is that they're going to wait until there's some level of consensus in the medical community and the scientific community so we can make an informed decision. A lot of places that are opening, they're opening perhaps based on economic reasons or other factors. So that's not really a factor for us. Our only concern is the well-being, the health and well-being of our congregants, of our members. So presently in our community, in those places in the United States that are cold, where there are not very many cases, they've begun opening the mosques there with social distancing. Everyone brings their own prayer mat. We do ablution from home. We don't do any ablution in the mosque. The bathroom in the mosque, the washroom is not going to be used generally. So all those precautions are there. And slowly those mosques are opening. But what we anticipate is that our mosque in Houston, since Houston is more of a warm, hot area where there are a lot of cases are rising, it's definitely more active with coronavirus or COVID-19 as compared to other parts of the United States. So for that reason, our Houston mosque might be in the last phase of mosques to be open in the United States. So we're anticipating a longer time staying closed. We're probably going to continue doing most of our things on webinar. We've gotten used to it. Our whole holy month of Ramadan, we had a daily classes happening on webinar. So our attendance has actually improved with online gatherings, and so that's our vague plan for the future. We don't have a specific date set for what we're going to do when we're going to open the mosque.
Gotcha. Perfect. And I'll ask these gentlemen again. Is there anything that's been the most difficult or the most concerning when you're thinking about and planning to have your congregants back in place? Is it the social distancing? Is it the face mask? Is it the hand washing? What do you think has been the most difficult to plan for when your public is going to come back into your facility? Jim?
I think some of the safety procedures and such have been easy. I think people are used to that. Many of the congregants are used to that. Of course, we're strongly encouraging people to wear masks. And I think people are very cognizant what I've seen of social distancing and such like that. I think for us, just the most difficult decision was, and this just affects worship itself, was to not have congregational singing. That's such a central core of what worship is. And I know for some of the members, that was a difficult decision for them to hear. And I think we were trying to convey why it was not safe to do that at this time. But that was probably the hardest thing. I've had to tell a couple of members who said, well, they're going to sing anyway. I had to sort of say, no, as your pastor, I'm asking you really not to do that. If you want to sort of sing quietly to yourself with a mask, you know, to reflect on the words. The worship leaders, Tommy, is actually in our worship. He's in our worship team. They will be singing and providing the music, but we're asking people to reflect on those words and not join in the singing. So,
yep. David?
The most difficult thing has been that when we begin to return, hopefully slowly this summer, that generally those who attend on Friday night when the Sabbath begins or Saturday morning for worship and study tend to be older people. And older people love to come and take the seat they've always sat in every week and to sit with the people they come with. And I'd rather be like my like Jim and Rizwan. We're not enforcers. We're leaders of worship. And we like to reach out to people. I don't want to enforce. I want to guide people to do what needs to be done. And like Jim said, providing the PPE and some of the other guidelines, I think we've all grown relatively comfortable with them. But coming in, our cantor who leads us in musical worship has great concerns about what it means for her to be, as she calls herself, a spreader. What does it mean for the choir over High Holy Days? So these are questions that concern us because, like my other worship leaders here, we want to affect the meaning in the worship, but we want to do it safely. And we don't want to lose the authenticity of it. That's a concern. But I think people are adaptable today. And even our worship and study that we're doing on Zoom, remarkably, attendance is up simply because it's on Zoom and they don't have to make the physical trek to the synagogue.
Right, right. Excellent. Thank you for that feedback. Rizwan?
Yes, so our congregational worship, it's unique in that we stand shoulder to shoulder in our worship. It's something that's done from the very origins, the beginning of Islam. So the guidelines that we've received actually from our international headquarters is that in such circumstances, it's permissible, not only permissible, but it's necessary to then put a 6-foot gap. So this was one point of apprehension, that how can we do congregational worship the way that it's been done for centuries, shoulder to shoulder, but with a 6-foot gap between each person. So that's not an issue. I mean, it was a bit of a concern before, but now we've received guidance on that. So if we open, and when we open in those places that we have opened, then there's a gap between all of the worshipers. Aside from that, you know, when we do anticipate opening, the only concern is just the possibility of people taking things casually. You know, we even before we closed our mosque, we've had for a few weeks the rule, which, you know, was the guideline that anyone who's an elderly member, you know, they shouldn't be coming. Children shouldn't be coming either. So that was already in place. Generally, those who were elderly weren't coming. There were just a couple who were particularly passionate, who can't break their attachment with the mosque. They would still insist on coming. That's always a little bit of an issue. But it's just people being kind of taking it casually. You know, there's such a cultural habit of shaking hands, sometimes hugging, maybe a feeling that, okay, if I don't shake this person's hand, are they going to feel insulted? You know, so that sort of thing, that creating that social norm, that it's wrong to shake hands, it's wrong to hug, it's wrong to not maintain that 6-foot distance, and to change the culture of the local congregation. That, I think, is going to be the main struggle which we're going to face.
Absolutely. I think everybody feels the same. Well, we've got some great questions that have been typed in here, so I'm going to start throwing these babies out. I think the first one has to do with the transmission in the ease of transmission for this virus. So this is probably maybe a George Del Close question, but you know, congregations talk, and congregants sing out loud, and they pray out loud. So what is that risk of transmissibility with this virus while they're at church? You know, praying out loud versus forcefully singing to the top of their lungs. What should we be concerned about?
Right. So the COVID virus is predominantly transmitted by what we call droplets. These are large in our field, which is still microscopic, but large particles that contain the virus. and that don't really travel more than about 3 or 4 feet when at a normal conversation level. That's why we talk about the 6-foot distance. It adds a protective layer. But we also know that a fraction of this virus is spread by what we call aerosols. Aerosols are much smaller particles, and they stay suspended in air for a longer period of time. They just don't fall to the ground. And so those are of concern because the longer they persist in air, the greater the likelihood of exposure of other people to it. So any type of action that favors the generation of aerosols is something that we would want to contain. And singing is one of those. There have been very well documented cases. There was, I forget exactly where the outbreak was, but of a gospel choir where, one person infected dozens of members of the choir, dozens, from one single episode or one single day of singing. So that's where a lot of this concern comes from. There's also transmission between people from a person who does not have symptoms, asymptomatic transmission, that we're also concerned about. And we don't really know what the method of spread is from somebody who doesn't have symptoms other than the droplet from normal conversation. That's in part the emphasis behind covering your face. So as Janelle said, when I cover my face with a cloth mask, I'm really trying to protect the other people from me. But if both of us, if 2 people, both are wearing masks, then they're protecting each other, and the risk of exposure drops dramatically to something like 1.5%. So that's not in lieu of social distancing, but it's in addition to social distancing. So we have to understand the modes of transmission. And in a congregation, I mean, all 3 of y'all have brought up the issues, right? Proximity sometimes interferes with religious beliefs, but social distancing can be implemented. Masking, you're going to have folks who may be resistant to masking, and that's where your abilities as a guide, more than an enforcer, as David was saying, are going to come in. Your art is going to come into that, singing and putting the limitations on that. Yeah, you have to have the modes of transmission in mind.
Hey, this is Bob. George, maybe we want to speak also about, the jury's still out, but the notion of fomites and environmental persistence on surfaces.
Yeah, as you mentioned, Bob, there have been several studies now that look at the persistence of the virus on different surfaces, and in some surfaces the virus is inactivated after about an hour, like cardboard. That's why receiving packages at home is not that big a deal, because from the time that they originated until the time they get to your house, more than an hour's gone by. But there are other surfaces where, theoretically at least, such as stainless steel, it can persist for longer periods of time. We know that transmission through fomites is possible. It is probably much less, or it definitely is much less than through the breathing route, right? And what was the other thing I was going to say about contact surface? Indoor versus outdoor settings. There's increasing evidence that being outdoors, especially in an area like Houston where it's hot in the summer, ultraviolet radiation levels are higher, that inactivates the virus to an extent. It doesn't make it impossible, but it does lessen the likelihood, which some people kind of are taken aback by that, because for so many weeks or a couple of months we were saying stay indoors, don't go out. And now we're saying, well, depending on the circumstances, being outdoors is okay as long as you maintain social distance. When you can't maintain social distances, you wear a mask. Houston itself, and I know this webinar is for the state, but in general, Texas is not a densely populated area. When you compare us to how people live, for example, in Boston or in Europe, the population densities are much greater there. Here, we're spread out. It doesn't make a whole lot of, it's not that big a deal if you're walking around in your neighborhood by yourself and you're not wearing a mask, frankly. A lot of this is common sense. So for surfaces, again, there is a risk of transmission. It is probably, the more we learn, it seems that there's probably less of a risk of transmission, which doesn't mean you shouldn't disinfect surfaces. You should.
George, I hope you don't mind if I jump in
Please
and
do.
share that Some of my colleagues around the country who do live in those northern climates look forward in the spring and summer to outdoor worship. I could only dream of doing outdoor worship in the spring and summer in Houston, but we are always locked indoors. And I, like Rizwan mentioned, bringing their own prayer mats. Some people do bring their own prayer books. In our synagogue, what we're able to do, because although we have many seats, we don't expect that many people every week. So we can actually have a prayer book, and the seats that will be used won't be roped off, and then rotate them out so that they're not touched for a few days or a week, and bring the prayer books that weren't touched into those places. So we're working on rotations to be sure that the touchable areas are either sprayed and disinfected or left alone for a period of time so that we can reuse them safely.
And we're doing something similar in that, but we've removed all our hymnals from the pews, all paper. We're not doing bulletins. Of course, we have multimedia in our sanctuary, so everything's up on the screens for us, again, to try to limit that common touching. We've also suspended communion for the time being. I'm still just not quite sure how to do that safely. And until that is figured out, we've just decided to forego that sacrament for us.
Mm-hmm. Excellent. George, another question came in that was asking about the transmissibility, that the World Health Organization came out with a statement and said something like people who are asymptomatic, it's going to be rare for them to spread the virus. The CDC came out and contradicted that and said, we don't agree with that. So what is the current thinking behind how easily this virus spreads if you don't have any symptoms?
Yeah, I knew this was going to come up. So the first thing is WHO does not have a policy statement about that. This was an individual at WHO that made a statement and then later modified it or even retracted it. CDC has monitored closely the risk of asymptomatic transmission. This means that the virus is transmitted by people who don't appear to be sick and they don't complain of cough or shortness of breath, or they don't have a fever. It is true, it is real. CDC currently estimates that about 35% of cases of COVID are transmitted through by people who don't have symptoms. So if you look at the paper today, you'll see that WHO is rapidly qualifying that statement, saying it came from an individual and it does not represent WHO policy.
Excellent, thank you. Another question said, I'm curious if because there's more testing, that's a reason why we're seeing more case numbers go up.
I guess that one's mine too. So I could have shown a more complicated graph that our folks here at the School of Public Health have described, where you're right. There's been this push to test, and it is true that Texas, like most other states, is making testing much more available than was previously available. Not at the level that we'd like yet, but certainly increasing. And so you might say, well, the more that you test, the more you find, so it shouldn't be a surprise that you see an increase in daily cases. However, there is a way from a statistical modeling standpoint that you can take in the information on testing, factor it in, and see how much of the increase of new cases is being explained by this increased testing. And our folks here at the School of Public Health have done that very nicely. I wish I could show the slide now, but even though testing is increasing, the rate of increase of positivity, the positive test, is increasing at a faster rate than the number of tests that become that are available. And so that tells you that testing might explain some of the increase, but it doesn't explain all of the increase. That's also coupled with other observations that I think are important to bring out here, and especially for our three invited panelists. Another thing to consider is that, some of the increases that we're seeing recently not only have to do with greater opportunity for people getting together, be it Memorial Day, be it the protests, be it some congregations have opened as well, but also the fact that people are beginning to experience precaution fatigue, meaning that they're starting to lower their guard. This is a I was just listening to the news last night. A good friend and the director of emergency medical services here for Harris County, David Peirce, was making that very point. You know, the people are starting to slack off on the masks, slack off on being together. I will explain an anecdote. I mean, actually, I've seen a few instances, even in our own medical center, of people wearing their masks very regularly, very strictly, and then they go to the break room, to the lunch room, and they take off their mask and they're within 2 feet of somebody else. Obviously, you have to take off your mask to chew food, but they're not thinking, or they're having birthday parties. We have a couple of instances where the exposure wasn't to a patient who was positive, but somebody who decided to either host a birthday party at their own home and invite a bunch of relatives. And since they're relatives, since they're family, they should be okay. So nobody was wearing a mask, and all of a sudden we have 5 cases positive there, or even at work, birthday parties that are being held at work. And it tells me a lot, because these are health professionals who technically should know better, right? But we're lowering our guard. And so we need to be careful. I think this applies to congregations as well.
Excellent. A question came in about the system, the symptom app. And the question is, does it give the end user the aggregate data, or is it just simply a symptom tracker?
For the end user, it's a symptom tracker, and then the results, well, they're already de-identified, meaning you can't trace it back to an individual. You can trace it back to their zip codes or their counties, and then that data is made available by our analysts here, our epidemiologists here at the School of Public Health. So in the slides that we gave you, next one, Tommy. One more slide. So the people here at the bottom, for more information, go to Dr. Sharma or Dr. Balasubramanian. They're the ones that are doing the analysis. Direct your questions. Feel free to send them an email and say, hey, I'm interested in knowing what the results are for X county, and they'll tell you how to get that to you. Okay.
Next question was for Dr. Emery. And the question is, where can we find that R0 value?
Good question. I suspect that the Texas Department of State Health Services, I'm going to defer to my colleagues here, but there's data flowing in from literally worldwide on what the epidemiological data is suggesting on what the R0 value is. I pulled this one. I think it was from WHO data, but George, help me on that one, right? Is it?
Yeah, both WHO and CDC have it. And you know, the R0 value for COVID, which is 2.2, as it's shown on this slide, that is that's the risk when you are unprotected. So if when you talked about an R0 for 15 for measles, that's unprotected exposure. 2.2.
Yeah, that's an important point. Yes.
And it's important because that means we can modify that R0 value by implementing interventions, masking, social distancing, all of the stuff that we've now memorized. That R0 value will go down, and the goal is that you will start seeing a drop in cases when R0 hits 1 or less, especially less. That means that fewer people are passing it on to others, and that's
and George, if I may, this R0 value will change dramatically once a vaccine is available. Correct?
Once an effective vaccine is available.
Well, no, I think people need light at the end of the tunnel. I think.
Yeah, and actually that's a very good point, because you know there was some hope, quote unquote, that the level of people in the population that were getting infected, even though they didn't know it, was going to be relatively high, so that we could achieve what's called herd immunity. That means when you have the majority of a population that has experienced the disease and survived it, and have now become immune to the disease, that in turn protects others, even those that are not vaccinated. But for that to be effective, you have to have rates of 60, 70, 80% of the population having experienced the infection to protect that remaining 10, 20, 30, 40%. And the studies are showing, for the most part, not only from the US, but from other countries, that we're nowhere near that level in terms of naturally acquired infections. So Spain has studied this very well. They had a huge number of cases, huge number of deaths. They have been doing some population-based screening for antibodies to see who has had the infection, and they're at about a 5-point-something% rate. That the 5-point-something% of the population, the general population of Spain, has had the infection. Well, you're not going to get herd immunity at 5%. So what can make it that up? It's a vaccine. Once you get people vaccinated with an effective vaccine, that number should shoot up as long as you have millions of doses of vaccine and millions of people vaccinated. And that's going to have to be the goal, at least with the information that we have right now.
Okay. A question came in. I think it's a real life scenario question, and I'll definitely ask our guest panelists questions about children returning to places of worship. How can we safely have kids back in Sunday school or attending the main worship area, but make sure that they are safe? And I don't know if there's anything special that our guest panelists are doing to assure that. Are you allowing Sunday school to kick back in? What are your thoughts on that, Jim?
We are not. We do not have our kids zone through summer, and then we'll evaluate it based upon medical advice. We do not have childcare. Also, we are encouraging families to worship together in the pews. We say the immediate family can group together and then have social distancing beyond that. We do have a cry room that we are reserving for anybody maybe nursing a small infant. But then we have a parlor where we're live streaming the broadcast for those who might have rambunctious children, where if they feel uncomfortable in the main worship space, that they could go in there, still maintain social distancing, but the kids could be rambunctious. Frankly, a lot of our families with young kids are staying home because of the lack of childcare, and will take advantage of online worship and such.
Okay.
That's our plan. So
thanks, Jim.
I think very much like Jim, we're doing the same. Our formal Sunday school program ended already, but even beginning in March, we transferred all of our in-person learning to Zoom learning. Attendance again was very good. We attribute that in part because the programming is good, but we acknowledge that parents needed an hour or 2 hours where their children are focused on something that they didn't have to prepare for them. So it went well. This summer, there's no in-person camp, and I should say that the Union for Reform Judaism that runs Jewish summer camps all across the country closed all of them for the summer. They simply cannot guarantee the safety of the children, the counselors, those who come from out of the country to serve as mentors and other kinds of advisors. It's a huge hit, a huge loss on many levels for the entire movement, and especially the children. The other concern that we have is that while some middle school or high school students could come and participate in a safe way, keeping a mask on a small child for the duration of the service, even if it's brief, could be very difficult. And they're not going to be as responsible as somebody who is older and understands the dangers. So we're trying to eliminate those opportunities for mistakes to be made and maintain the safety for everybody who might enter the building eventually.
Right. Okay. Rizwan?
Yeah, so before the lockdown started, we had already asked the children and also elderly not to come to the mosque. And since then, it's been that way. I think here in Houston, the public schools, they had gone on spring break in the beginning of March, and then after that, it had been closed ever since then. So our mosque closing for children had coincided somewhat to that. And I think likely we'll probably have children come to our mosque for classes again around the same time that public schools open. So I haven't heard anything. I mean, at least towards the end of the spring semester, they were giving weekly updates that we're not going to be opening until for the next few weeks, until it got to a point where, you know, the whole semester was just canceled. So we'll see. I mean, if the fall semester, the public schools start opening, then we'll also probably follow in the same line.
You know, and as you guys were just talking, it dawned on me that, you know, places of worship sometimes will fall into multiple categories of places of business. Not only do you have the guidelines for the worship center, you have the guidelines for the child care center, then you have the separate guidelines if you have a Catholic bookstore attached, the retail guidelines. So sometimes I cannot imagine what you have to understand and go through to be able to open up safely and cover all of those bases. So all the more praise to you.
Tommy, can I butt in for a second? So the other thing, and I'm sure that all three of you have considered this, is it's not only about the congregation. You also have office staff, and need to protect them. Remember that the unfortunate case of Holy Ghost Church here in Houston, where an elder priest died from COVID and had spread it to another 4 or 5 people. And the initial impression was that these were members of their congregation. It was actually office staff in the majority of cases. So you need to preach what you need to practice what you preach. In this case, more with respect to your own staff.
Yeah, one of my pastors, she is a high risk person. Had some heart issues and a cancer survivor, and she's actually been, we were pretty insistent early on that she had to step out from interacting with anybody, and so we've been wanting to be very cognizant of that too. And as we reopen, to make sure things are disinfected so we don't put in jeopardy some of the staff who are up here.
Right, and in our place we have a Jewish bookstore and for other Jewish ritual items, and there are people who generally come by the synagogue if it isn't for a class or for a visit with the rabbi. It's just to pop in. They really miss that contact. But even our accounting department that takes care of expenses for the synagogue or revenues for the synagogue, we're creating a staggered work schedule and implementing many of the standards that you're speaking of to be sure that we're complying and creating safe spaces. The challenge that we're facing in some cases, and I don't think it's unique to us at all, is that as much as we create a safe workspace, sometimes our members of the staff go home and into the community and do things that are not safe. And then they come back and there might be an issue there. So it is persistent education, taking the guidelines home with you, and then coming back to a place where that we regard not only to be sacred, but also to be safe for everybody who enters.
Excellent. There was a comment and question that came in, and it's a really good one. Is that, as the places of worship are going through these motions and the phases of when to open, how are you dealing with disseminating that information easily to people? And especially if you have an older group of people who may not have access to the internet and may not get emails, how are you making sure that, to the best of your ability, everybody in your congregation is receiving that information and guidance? Maybe I'll start with Rizwan this time.
Yeah. So we have emails that go out, of course, and then our WhatsApp groups are quite active. I mean, you're mentioning that those who are older and don't have access to internet, and I think some of our older members are a little bit too active on WhatsApp, if anything. So there's definite activity happening there. I don't think there's any members of our community who don't, are not active on, a chat group or something like that. So we found, those chat groups to be a place where, especially during quarantine, especially since older members are in quarantine, that social interaction has to be filled somewhere. So there's actually an increased activity on social media, on these kind of chat groups. So for that reason, people are actually more closely monitoring the messages that they get. So I think from our end, when we send out that announcement of updated information on when the mosque will open and things like that, I don't anticipate there being any problem of the message getting to the members. I think it'll get there immediately, and it'll get there better than it used to get before. It used to be received before.
Interesting. That's great. David?
Yeah, I think Rizwan is right on. Our older members are taking to technology faster as a result because they crave the socialization. They want to see their grandchildren and their great-grandchildren. And time for them in Torah study or in worship is so meaningful to them during the week. In addition, I create Zoom sessions just to have a private conversation with somebody. And even if it's 20 minutes or an hour, it's so meaningful to them, and frankly, it's very meaningful to me too. And by way of the messaging, we've been very careful to craft the message so that it doesn't mislead or overstate. We're not trying to give medical advice because we're not doctors. So my point has been, let's be vague but not unclear. And people are hungry to get the next message so that they're getting the latest based on what we know, and we can guide them safely.
Perfect. And Pastor Jim?
I think similar. Surprisingly, a lot of our older members have become very attuned to the internet and technology. Of course, that process has been going on for a while before COVID. So we have individually reached out, and we've noticed family members have reached out to some of those persons who still have difficulty with the technology aspect, and have helped them to do that, to see the online services, provided multiple opportunities, not only our website, but also through Facebook, through direct messages and such. So we've not seen a real problem with that, and those individually we've tried to correct.
Good. And I guess the old-fashioned telephone still works too, if you needed to get a hold of some of those people.
We did, actually, the entire staff did that. We've contacted the entire congregation several times throughout all this to see how they were, what their needs were, and also been able to relay some information to folks. So that, yes, we went old-fashioned, old school in that.
A question came in, and I guess we'll kind of poll the guest panelists here, but it was, how many people usually attend your services at your house of worship, and will you limit that number as you open? Rizwan, you want to start off there?
Yeah, sure. So for our Friday service, we might have a couple hundred who join, maybe 100 or a couple hundred, something like that, depending on how that particular Friday. Our Eid service, which is our annual service, there our mosque is completely full. So our mosque is a quite large one. And so when our programs start again, then I think that for our regular programs, even for our Friday prayers, with the social distancing, our facility is big enough to accommodate our regular membership. So for example, if 100 people come for Friday prayers, or maybe 150 people come, or 200, then I think with 6 feet difference separation when everyone's standing in their rows, we could probably accommodate that in the building. So since our facility is large, and it's only used to its full capacity a couple of times a year when we have a major program, so I think we will be able to accommodate that the members with maintaining social distancing.
Excellent. David?
Yeah, Rizwan, it's so similar. In the synagogue, our space is large enough that on a Friday evening, when we might ordinarily have 200 or 300 people, if we open the back doors and use the social hall space, we could create the social distancing that we need. The only part that's going to be eliminated in the short term is the socialization that takes place after worship. Mm-hmm. We call it Oneg Shabbat, and there's a lot of good food to share, but we're planning on having some to-go bags so that people can take a little food home with them. But I think opening up the spaces to their full capacity to create room is exactly the model that we'll follow.
Okay. And Jim?
Yeah, very similar. Our worship center, our sanctuary, can house about 1,100 people. We'll typically have about 800 on a Sunday morning, but that's spread out throughout the morning with multiple services. So we do know that a lot of our older people are not intending to come back for right now. And so we feel strongly that we can rope off the every other pews, maintain social distancing, and still provide enough space. We have no idea what we're going to do for Christmas Eve, where typically we might have 2,600 people packed in. We know that's not going to happen. So we're looking, if we're still dealing with this, with most likely, I guess we may be, how we would do that through probably just a lot more services.
Mm-hmm. And this question came in, it was directed towards Jim, actually. And the question is basically, what led you to decide, I think we're ready to open up the services on this date? Was it clergy driven? Was it congregation driven? What made you feel comfortable to say, I think we're ready?
It was a lot in terms of discussions with other pastors and other churches, large churches similar of our size in the Houston area. We had guidance from our bishop. There are certainly discussions listening to medical professionals and such as to how we could do this safely. So, I mean, that was the primarily, there was a lot of discussion. Do we wait till July and such, or is it go ahead and safe to begin to reopen now? I guess we came down, we felt like that with proper social distancing, all these procedures and such, we could go ahead and reopen now. You know, obviously knowing that if things continue to uptick, we may have to close back down again. So just trying to follow some of the guidance from folks.
Okay, excellent. Here's a quick question I'll throw this out to Bob Emery. And I almost asked this when we were talking about it, but define a fomite. When we talk about fomites on surfaces, what is a fomite?
I'm sorry. Yeah, fomite would just be a viable product that was on a surface. So something, think of handrails or doorknobs or that sort of thing that early on, going back to one of my key points is that this being a novel virus, there's still things that we're learning about it and how persistent might the virus be on a surface. And as George mentioned, it varies by the substrate, you know, is it cardboard or stainless steel or whatever. So a fomite is just, think of it as something on a surface. But I did want to throw in something with the previous commentary, the notion of air exchanges and ventilation rates within your respective facilities. One of the things that we're seeing is that, as George mentioned, the means of transmission, it relates to the air exchanges that may be within a facility. And but air exchanges, which is often referred to as ACH, air changes per hour, I would just strongly encourage you to work with your respective facilities people or your contractors. But what you're wanting is to make sure you're getting outside air in and not just recirculating the internal air. George and I and others, Jennifer Lane, who's down at the University of Miami, just completed a big study on this with regard to outpatient clinics. And just kind of as a rule of thumb, in a clinic where they might be doing airborne, let's say some procedure that might result in sputum or that sort of thing, the guidelines would be somewhere in the range of 4 to 6 air changes per hour. But that the important point here is it's bringing in outside air, not just rattling around the stuff you already got in there. And I'll defer to George on this one, but in this current environment where people might be potential carriers or someone who can infect others, that 4 to 6 room changes per hour to me sounds very reasonable. George, would you agree? Or?
Yeah, I mean, I think the take-home point is we'd suggest, you know, like any public place, to consult with your HVAC folks, right? Mm-hmm. And just ask them, you know, how many air exchanges do we have, and is that adequate for the situation that we are anticipating when we reopen?
Well, and is it outside air, not just rattling around?
Right. So there's a difference between ventilation and recirculation. Ventilation means replacing indoor air with fresh outdoor air. That's what air conditioning systems are supposed to do. Recirculation is, imagine you have a room and you block it off completely. You hermetically close it and you put a fan in the middle of the room and turn it on. All you're doing is stirring up the same air that's not being exchanged. And not only is it not effective at decreasing the levels of circulating bacteria or virus, it actually makes it worse because it prevents that virus from falling to the ground, right? So it stays suspended longer because all you're doing is moving it around. So you need to think about that, especially in situations where fans are used.
Okay. Right? And what, I'm sorry, Tommy, while I'm on the podium here, we've received a lot of questions about filtration, but also inline UV light treatment devices. So in other words, imagine that in your ventilation system, they can actually install these commercially available devices that are a series of UV lights. And as I think it was George mentioned, this particular virus is susceptible to UV exposure. And so there are many commercial operations offering these services. But I think I say this every week, this is fine if you want to put them in, but understand it's like getting a puppy. You got to walk it, you got to worm it, you got to feed it, all the other things. So you put these things in your ducts, but then they get laden with dust or whatever, they're not effective. And so just understand there's some care and feeding that goes along if one decides to go that route. I'll get off my soapbox now, Tommy. It's all back to you.
No, you're good. You're good. So it looks like we've got about 3 or 4 minutes left. I think we have about 9 questions left. So I'll try to spit these out very quickly, and just if somebody can give a quick answer. And I think it's mainly geared towards to Bob and to George and to Janelle and Dave. Here's one on testing, George. It says reportedly serum testing has been very unreliable, showing false positives. Is there a reliable place or method of testing for serum testing for the virus?
So there are 2 different types of tests. One is the swab that swab in your nose. Some people call it the swab to your brain. That is used. That is to detect active infection. It actually looks for the virus or parts of the virus. What I think people are talking about now in the community are more antibody tests, which are blood tests typically. And any test has false positives and false negatives. That means it's reading that you may have had or had the infection when you didn't, and vice versa. So all tests have that. What you're looking for ideally are antibody tests that have the lowest rates of false positives and lowest rates of false negatives. So there are some out there. I would recommend that if you look for them, that you go to the FDA, the Food and Drug Administration website, where it lists the one that they, as an agency, have validated. They've checked to make sure it's accurate. And we don't have enough time to talk about how you interpret that. But yes, there are issues of quality of the tests. And then the separate thing is the interpretation, which we really don't have time to get into today.
Kind of a double part question, and maybe George, maybe this may be geared towards you. I would ask Christy if she was here, but for the low income communities and maybe the undocumented communities, what resources do they have to go get tested, to find free PPE? Is there a good resource for those communities?
Certainly for testing, typically the public health department, whether it's county, city, the state health department doesn't have that many testing sites, but you can get tested for free. For PPE, I would encourage people, you don't need to go to a place. You can make your own cloth masks, and there are plenty of websites, especially the CDC, have videos that are 30 seconds long and show you how to make a mask covering for yourself. I think that's the best way to do it. And then I would not focus so much on skin disinfectant, skin sanitizer, and think about soap and water. Soap and water works. Originally, when they talked about all these skin sanitizers, it seemed like it was the only game in town. And actually, if you look at the instructions carefully, it says when you don't have soap available and water, then use a skin sanitizer. But I think even people with meager resources have access to soap, water, and pieces of cloth like old T-shirts that they can make their own masks out of.
I'll end with this question. It was kind of a 2-part question, but the writer says that, at least in their experience, people in congregations or places of worship tend to err on the side of, we don't need to go through all of this nonsense to decrease the spread. We're going to be fine. This is a lot of media hype. I don't think we need to be wearing masks. Do you, for our 3 guest panelists, and we'll close with this, do you see some of that in your congregations? And if so, what do you think can be done to educate? Jim, you want to start with you?
Yeah, I've seen some of that and comments and such. What we have really done from the very beginning is we've asked people, what does it mean to love your neighbor as yourself? And that's what we really hit hard on. And that, that this is what we're trying to do, is to protect those who are vulnerable. who, if they come down with COVID-19, it could be a very serious health issue for them. And so from a spiritual standpoint, instead of just trying to argue all the medical aspects, which I am not a doctor, we've been really pushing the spiritual aspect of, again, what does it mean to love your neighbors yourself?
Excellent. David?
Yeah, Judaism values life, and it's only in life where we can do the mitzvah, the commandment, and fulfill our partnership with God. So in Deuteronomy, we emphasize, it says, God has given us life and prosperity, death and adversity. Choose life. So life and health comes first. And sometimes we say, pray as if everything depends on heaven, and do as if everything depends on you.
Excellent. Rizwan?
Yeah, we haven't faced too much resistance. Maybe just from a few individuals who just are looking forward to the mosque being open. But then when I tell them that this is what our guidance is from national, these are what our instructions are. So I mean, everyone's waiting patiently, especially those who are anxious. But as far as the general feel among the members of the community, it's just I don't really see a trend towards kind of denying or to be resistant towards what the medical or scientific community is saying. We're just waiting for when it's best to open, and then everyone's looking forward to that.
Excellent, excellent, excellent. Well, it's 2 minutes past the hour, so I'm going to go ahead and wrap it up. I think we did not get to about 5 questions, so I'm going to email that out to our panelists, and we will disseminate all of that information out to our attendees. So thank you for all of our attendees for jumping on. I saw we had, somewhere between around 150 attendees today. So I think that's a great turnout. Thank you to our panelists again. We thank you. We wish you good luck in opening up your places of worship and keeping everybody safe and healthy. So enjoy the rest of your weekend. We'll see you next week for the next webinar.
Wonderful session. Thanks, folks.
Thank you.
Thank you.
Thanks.